So with that announcement about the recording, I think it is our signal to get started. My name is Margaret Fitch, and I want to welcome everyone to this Canadian Cancer Survivorship Research Colloquium. We are looking forward to a very interesting presentation this afternoon. And I'd like to say, first of all, that I have been involved with the network for a number of years now. From my Toronto location, but just at the moment I'm coming to you from Rwanda, where I'm working for a few months. So if you lose me, don't worry, Athena is going to take over. She is ready and my backup. I'm delighted when I reached out to Megan when she said yes, she would join us this afternoon. And Dr. Megan Delisle is a complex general surgical oncology fellow at the University of Toronto. She finished her surgery preparation at the University of Manitoba and also has a master's in public health from Harvard, a master's in science and surgery from the University of Manitoba, and is looking forward to starting a new position at Cancer Care Manitoba in the Research Institute and an assistant professor of surgery at the University of Manitoba in July of this year. This afternoon, she's actually coming to us from France. She is in Paris at a fellowship. So we're an international group today. And I had the opportunity to work with Megan on two analyses, two articles that pulled from the transition study that was done several years ago. But I'm quite intrigued with Megan's view around the goal of her research work and finding solutions to increase the impact of quality improvement and innovation in cancer care. So everyone can silently clap and welcome Megan. And at this point, I will turn over to you and say welcome, Megan. We'll have a Q&A afterwards when you have finished your presentation. Welcome.
Thanks so much for the kind invitation and for having me. I'm really grateful for the opportunity. And I promise I will be discussing the work that we did together, but I'll just discuss it in kind of the broader context of something I'm very passionate about. But I will be diving into those aspects of our work together. And I'll go ahead and get started. Okay, so I guess I want to lay the stage for the work that I did with Dr. Fitch, as well as using the data from the transition study survey by starting a bit, giving some perspective on what my passion is and something that I hope to change over my career. And that's this idea of system improvement. And what I see, where this comes from, is that every day I see problems in the system, just like many other people. And we want to do the best we can for our patients. And we have all these ideas of how we could deliver better care to our patients. But then when we go and try to do those things, oftentimes we run into roadblocks with REB, quality improvement, all this kind of lingo that we don't really understand. And at the end of the day, I think people just get a bit frustrated and don't really know kind of where to go next. So all these ideas that they have just kind of funnel down into this. Very few of them actually make it to impact. And I think and when I say impact, I mean patient impact. And this can be kind of conceived as a leaky pipeline. And many people have probably heard this, but it takes about 17 years for an idea to make it to patient impact, is what they say. And only about 6% of ideas ever really make it to impact. So this is really where my passion is trying to reduce the loss of ideas along the way. And a lot of that, I think, comes from this idea of, okay, I want to change something, I have an idea, and most of these changes come from these things that we see in clinical practice and from system failures where it's just not right that this is how we're providing care and we want to do better. And so these are moral dilemmas, and day after day we see these, and particularly during COVID, and that leads to moral distress. And then what they say in this, I like this model a lot. What they say is that if you don't have the ability to change these things, then it kind of goes from moral injury to burnout. And the CMAJ recently published the statistics, and the rates of burnout amongst physicians increased 20%. I think it was now 50% in 2017 compared to 2021. A large part of that is probably because of the pandemic, but I think a lot of it is just we feel like we can't really change anything. And as a consequence of this, what we do in clinical practice and what we know we can do and what we want to do for our patients, often the gap between those things keeps growing and growing. And I really want to be able to bridge that gap. And so what we need to do that is kind of a systematic, logical, reproducible, measurable way for system improvement. And this is where the work around the transition study survey comes in, is that we really need to make sure that we're always going from trying to get the highest impact, and that's really making change in the system and even kind of creating hypotheses, generating hypotheses for what we want to see in the future as well. And so through my research and through my work, I've kind of come up with this system that I'm trying to approach system problems to, including the ones that I'll talk about from the transition study survey. And it's this 3-step, it's kind of 2 different phases. The first step is defining the problem. So it's first asking what gaps exist, meaning what gaps do we want to change in our system, and then understanding why these gaps exist. Then finally, how can we close these gaps? And this is really borrowed from the learning health system literature. But then when I was in Boston, what they did really well is designing the solution. And that's designing a solution that's really acceptable and usable for end users, and then testing it, making sure it's feasible in the real world and effective, and then spreading it. And that's borrowed from Ariadne Labs. So it's with using these kind of tools and skills, I hope that we can go from having that funnel shape to having more of this kind of square almost, so that all the ideas that we have really make it to impact. And that's where so I want to use that kind of framework to apply it to what the work we did with the transition study survey, and potentially some ideas of where we should go next, because I think this was really amazing work, and I hope that it continues. And I hope to have some discussion around kind of what we could do next with this. So essentially, when I started my fellowship in Ottawa, Dr. Srikanthan, who's pictured here, approached me because they wanted to improve their cancer survivorship program in Ottawa. And so what she wanted to do first is like, well, what existing data do we have to understand gaps in survivorship care in Ottawa? And in the United States, they have a lot of publicly available data, but actually in Canada, we don't have that much publicly available data. And I was very, very surprised it was Dr. Srikanthan that drew my attention to this study, and it was such high quality publicly available data, and it's truly amazing to see that this is available in Canada, and I think it's really one of a kind in that way. At least my scope of interest is really limited to oncology, so it might be in other areas of healthcare, but I think in oncology this is really kind of a unique initiative. So essentially in 2014, they identified that they wanted to learn more about how survivors were transitioning out of their active treatment in the first few years, because that was identified as obviously a very high stress time, going from very active treatment to maybe less active treatment. So stakeholders gathered together in about 2014, and then in 2016, they designed the survey, collected the data in 2016, and in 2019, I believe, was when the first kind of publication that I'm able to find was released. And Dr. Fitch, please feel free to chime in if you know this trajectory much better than I do. These are just pieces that I've learned from speaking with people and reading a lot of the stuff that has come out of this. And so the main questions that they sought to answer with this survey was, what are the needs of cancer survivors 1 to 3 years after treatment? Who are the most vulnerable cancer survivors? And what personal characteristics and system factors are associated with poor versus good outcomes in cancer survivors? So they developed a survey with 10 provincial cancer agencies, multiple stakeholders, and then they piloted it with cancer survivors. And then, as I mentioned, they disseminated it in June to October 2016. Around 40,000 packages were sent out, and it included anyone over the age of 18 who completed primary cancer treatment within the last 3 years. and included non-metastatic breast, prostate, colorectal, hematologic, testicular, melanoma, and I think some metastatic as well in certain cancer types. And really, there's been a wealth of publications that have come out of this. I've tried to find them all, and I think I'm still missing many. And that's one of the questions that I'll ask at the end is kind of, how do we collate all this information that we've learned through all these publications into one report? Is that the plan? Is that already available and I just haven't found it? Because really, there's so much data that has come out of this, and just kind of trying to get the big picture view, for me personally, has been, and I'll talk about this at the end, so maybe I'll just leave it. So going back to what Dr. Srikanthan's question to me was, well, what gaps in care exist and how can we use existing data? So it was very clear that obviously using the transition study survey, which was publicly available, very clean data, very easy to use, because you can say, well, ICIS and all ICES and all that is also potentially available, but it's very hard to get access to. It costs a lot of money to get access to. It's very hard to use through their system. So this was very, very easy to use data, which is a huge benefit and probably why there has been so many publications from it. So to get familiar with the data, and see how we could use it to kind of inform the next steps for survivorship care in Ottawa, we wanted to learn how to use it, what was available from it. So we tackled 2 different projects that hadn't really been looked at yet. That also kind of informed some questions that Dr. Srikanthan had about survivorship care. So the first one was looking at experiences, factors that influenced experiences. So there was a lot of work that had already been published from this about experiences, but not so much about the different factors that influenced it. So we wanted to dive a little bit deeper into that. And then I don't think that emergency service utilization had been really looked at all as its own kind of separate thing, which is obviously important because as I'll mention it a bit later, but so we thought we could add something to the literature by looking at these 2 aspects. So I'll go into the first one, then I'll present the second one after. So the first one was factors influencing cancer survivors' experiences. So this was really, the rationale for this was that we know that there's evidence suggesting that any patient, really not just cancer survivor, their experiences directly impact the potential benefits they can get from their care, and sometimes can even influence their outcomes like survival. But there's very limited real-world data on the factors that are influencing the experiences of cancer survivorship care. There's a lot of stuff published from trials, but not really a lot from real-world data. So that was the goal of that study. We divided the factors into individual and structural factors, and there was a systematic review that was done by LSC, which I have down here, which really helped inform how to think about the factors, because they had found that in cancer patients, not cancer survivors, that they did a systematic review and found that these were dividing it like this, and was how they had it structured and how they kind of started to map the different influences, because obviously experiences are very hard to understanding what actually influences experiences is a really complex topic. So we used their model. Our main outcome was this question, and there was 4 sub questions to the main one, but we did some tests, and it showed that it was probably okay to just combine it into one because they were all very highly correlated. So in total, we from the initial survey, there was 13,319 respondents. So it was a 33% response rate. We included breast, hematologic, colon, melanoma, and prostate. And then after going through our exclusion criteria, we had a total of 8,402 patients, of which about 63.1% of the respondents. So I'll just highlight I have a few tables about the individual factors and structural factors of our patient population, and I'm just going to present it for this study because the second study was very similar in terms of who we included. So essentially, and what we did, and this I think was the reviewer actually suggested, which I thought was a really good idea. And so we looked at included versus excluded. So based on our exclusion criteria, how did our population differ? And so first, overall, you can see that the 18 to 29-year-olds represent a very small portion of these patients. But we can see that our patients that were included in our study were more likely to be employed, were more likely to have, or less likely to have less than a high school diploma. So they were more educated. So our population was more likely to be employed, more likely to be educated, more likely to have private insurance, more likely to have a good quality, report a good quality of life, as well as good emotional health. They were more likely to report an unmet need than those that were excluded. The cancer types you can see here, we included more breast patients, as well as prostate cancer patients. I'm really not sure why that would have happened. I guess maybe based on their other inclusion criteria. They were more likely to have received multimodal treatment than the excluded ones. And then when we looked at structural factors, which were things like did they feel comfortable asking questions about their concerns, the ones that we included felt more comfortable. They were more likely to be followed by their oncologist or their oncologist and primary care provider. They were more likely to receive a survivorship care plan and report that their care was well coordinated, as well as report having social supports. So this is really fascinating to me because I guess it was just incomplete survey. I'm not sure like where people dropped off, but it's just fascinating just based on this, how homogeneous our sample is relative to those that are excluded. And I think that's really important to remember when we're talking about using this type of data to improve care. So overall, 81.8% reported a positive overall experience, which we defined as rating good or very good. And you can see these are the 4 subscales from the question, and you can see all of them are very high. So they felt that, care met their needs, the right services were there when they needed them, that they had access to the right services, and that the care was personalized. And as I mentioned, the ratings on these scales were highly correlated. So we just were able to combine it into one for ease of analysis. And then our multivariable analysis. So these are some of the individual factors, just the ones that were significant that I'll highlight for you. Those that had a less than a high school diploma reported having a better experience. So it was interesting that the more educated ones actually reported a worse experience. Those that reported a better quality of life reported a better experience. Those that had a better emotional health and had no unmet needs also reported better experiences. And then these are some of the structural factors, and you can see that these are much higher odds ratios, and also the p-values, like the p-values and the odds ratios were much more were much higher and more. It seemed that the structural factors overall seem to be much more significant predictors of having a good or very good experience, which is very interesting. So people that felt comfortable asking questions had a better experience. People that were followed by their oncologist reported having a better experience. Those that had survivorship care plans or that their survivorship care coordination was good. And it was quite surprising just how high the care coordination seemed to really impact their experience. So from this, I think it's quite remarkable that 81.8% of patients said that their overall experience was good or very good. But again, I think we always have to remember, well, which voices are we not hearing in this? And then the structural factors seem to be more consistently associated with a good or very good experience. And so it's interesting because when I go back to the Alessi's systematic review, that was the one who looked at structural versus individual factors for cancer patients, they actually found that it's the opposite, that it was the individual factors and not the structural factors that were more important. And so one idea that I'm like, how do you make sense of this, is that maybe that once they're in the system, so they've already had their treatment, they're in the system, they're known to the system, then the individual factors that would potentially be barriers to accessing care, like socioeconomic status and things like, and health literacy, aren't so relevant anymore. The other thing is, well, what voices aren't we hearing? Are we just having a very homogeneous population of people that can access the system, hence why they responded to the survey? Is it our universal publicly funded healthcare system that those disparities go away? So those are just some of the ideas that have come from this. I think one thing that the reviewer really kind of really wanted to push us on talking about even more in our discussion was this idea of oncology specialists, of the fact that patients seem to like oncology specialists or have a better experience with them. And this was really discordant with this huge, it was a systematic review of systematic reviews that included 53 primary studies, 12 systematic reviews, and they found that equivalent or more positive experience with non-oncologists or shared models, which is not what we found. And so the only thing that I can really see is this idea that these were mostly interventional studies in controlled research environments, and there's been very limited experiences being published from the real world setting. And I think there is a lot of implementation challenges with primary care providers in the real world that potentially is what is happening. That's just one hypothesis. And there's been some surveys from, I think, mostly out of Ontario, looking at, medical oncologist perspectives and primary care providers. And I think one thing is that primary care providers really appreciate survivorship care plans that are transmitted to them. And we know that only 40% of the patients report having one. So are we underutilizing them? I think there's a lot of questions that are still unanswered around why this finding was discordant compared to the literature. So then moving to the second article, which is the emergency service utilization. And so really where the rationale for this study came from is that this Nekhiludov, I'm not sure how to say that person's last name, but this author here came up with this framework for assessing kind of quality of survivorship care. And one of the main outcomes they actually suggested to use as a quality indicator or quality metrics is emergency service utilization. And so this is very interesting to use this and I'll talk a bit about, so kind of we said, okay, well, let's say we use emergency service utilization as a quality metric. What does this really tell us? So the premise is that if patients are using high rates of emergency service utilization, that could potentially be a negative thing. And that, it represents not efficient use of resources, fragmented care, because really patients should have potentially alternative ways of seeking that care. But relatively little is known about how and why cancer survivors use emergency services utilization. So I think it was interesting that they recommended this as a quality metric when we know so little about why cancer survivors even use emergency services, and what information does that provide to health systems, and how should that information be used? So we wanted to understand the factors associated with emergency service utilization during the first year, and then after cancer treatment, and then to assess how emergency service utilization, primary care provider, and oncology specialist utilization in the 3 years after completing cancer treatment were related. So for this one, we use still the individual and structural factors, but I think we also tried to inform it a little bit using Anderson's model of health service use. This is all secondary analysis of the survey, so obviously we didn't have every single factor that we would want, but I think that the survey was really, really well designed, and there's a lot of factors that were included. Our main outcome was this question. So we really looked at the 12-month. This was emergency service utilization in 12 months, 1 year, second year, and third year since completing treatment. And they asked them for emergency services, primary care providers, as well as oncology specialists. And then the possible answers were not at all, 1 to 2 times, 3 to 4 times, or 5 or more times. So emergency service utilization after cancer treatment in the first year, 78% reported none. And then the second year, 92% reported none. And then the third year, 94% reported none. And I'm not going to show again the patient population in this study is so similar that I'm not going to show the tables again because they're pretty much identical. And I just wanted to highlight a few things that were associated with increased emergency service utilization, which here is defined as greater than 3 times. And it was interesting because it was the younger patients between 18 and 44 that were less likely to use, that were more likely to use emergency service utilization. But then the story didn't hold, because then patients who were retired were more likely. Patients that had report a good quality of life obviously were less likely. Those that had an unmet concern were more likely. Those that had more comorbidities were more likely. And then there was a lot of variation by cancer type, which was really interesting. Patients that had colorectal cancer had the highest rates of emergency service utilization. And then one thing is that we often conceive emergency service utilization as like kind of patients aren't really potentially like the care coordination isn't good. There's in the literature that seems to be a common theme is that emergency service utilization is associated with low value care and fragmented care. But what we saw is that they actually had more use of primary care providers and oncologists. So that was highly correlated. And then when we looked at kind of how emergency service utilization the first year after cancer treatment compared to the use of all three services in the second and third year, we saw that there was kind of two phenotypes, that patients that were high utilizers in the first year remained high utilizers of all three in their second and third year, compared to patients that were low utilizers kind of stayed low utilizers. So it seems that there's these two phenotypes of patients. And so some conclusions that we can draw from this is that the factors associated with emergency service utilization are very varied. And the reasons for emergency service utilization are very multifactorial and complex. And I think they're very specific to local context. So it's hard to generalize findings from one area to another area. And it's really hard to use emergency service utilization as a quality metric without understanding why people are using it. And I think in general, then without this additional information, it's really hard for it to lead to meaningful system improvements. And this systematic review was very interesting because what they found is it's just not the term that's recommended emergency, using kind of how frequently they're using emergency service utilization, can be measured in many, many different ways. So I think they said, like, is it number of times that they visit? Is it how long they stay in hospital? Is it kind of what the diagnosis was when they got to the hospital? Should we be looking at appropriate emergency utilization? Is it preventable emergency utilization? And this systematic review found 14 different ways to even measure emergency service utilization, and that each of these things represented a different aspect of care. And so I think if we're trying to think about measuring quality of survivorship care, it's really important to look at it from all these different perspectives. And so I just want to go back to kind of where we're going with all this. And the original question that Dr. Srikanthan had asked us is, how can we use this how can we use this data to understand the gaps in care in Ottawa? And so the next step would be to try to go to why do these gaps exist? But I think obviously if you take a step back and say, okay, well, why do these gaps exist and how can we improve care in Ottawa? I think this is where a lot of people would get frustrated and be like, well, I don't understand where to go next. Like, where do we go next from this data? And I don't blame them. It's really hard to make this leap and to think about that. And I know that this survey wasn't designed with that intention, but I think as providers, we're trying to do the most we can with the minimal resources. So this publicly available data is a bit of a goldmine to try to inform our own practices, even though it wasn't designed for that. And so kind of in order to make the leap to where do we go next, I think we need to go from this big data, which is kind of this publicly available data, and go into more deep data, which is focused, in-depth, granular, more at the hospital, surgeon, and patient or provider level. And then I think taking a step back from even that is like, where do we go next? The transition study survey has had so many publications, but what has the impact been, and like kind of where do we go next with this data? Where do we go next with this work? And where do we go next with this momentum that really has been built from this? And how do we make sure that we're getting the highest level of impact from the momentum that's already been built around this study? And so what I like this idea a lot. I've used it a few times, and I think the idea is that, in Canada, we have I have an example of the NHS and how they're doing things a little bit differently in Canada. But in Canada, each province and even each kind of health network, like UHN does things very differently than Ottawa, which does things very differently than Montreal. And we're all kind of like recreating the wheel each time. So we all have we're all trying to get data from our practice in different ways. And then some people are able to kind of go to higher levels of impact and turn that data into knowledge and knowledge into practice. And then finally, some people are able to make quality improvements at their system level. But I think what the transition study did really well is that it was a way to get everyone kind of, really what we wanted to see at hopefully a national level. And I have an example of the NHS and how they're doing this is, well, the transition study really got data to everyone using the same way. And then hopefully what I hope comes next is that we can continue to have these like national initiatives so that people can use this information and improve care without having to think about, okay, well, how am I going to improve care? It's really providing people with the tools and resources for them to make change in their local context and their local systems. And so this is an example of the NHS. So if you go to the NHS website, they have all these tools that you can use in your like local environment that is aligned with NHS and NHS funding priorities. So it would be easy to get grants with these things. And I worked in the NHS for 3 months earlier this year, and they're kind of mandated to do this through the NHS. So a lot of them have to show evidence that they're doing some of these things. And they've done a phenomenal job with a lot of their survivorship work, and they have this kind of self-management model that they've instituted. And when I was there, they were using that quite a bit. So patients are assessed and triaged into 4 different kind of models of survivorship care. Not all of the cancer types are eligible for this. I think breast is the main one that they use, the self-management. But I think they were able to roll this out, I think in 2011, 2012 is when they did the pilot sites. And they were able to do this because of national coordination, that they were able to achieve like such a large scale project with such an impact. And really, so I want to thank you for this. And I hope we can have some discussion about maybe it's just because of my lack of trying to understand where we're going next and just being new to the field, starting my practice and stuff like this. But I am really interested, and I hope there's something that's coming next from all this work. And so one final thought is that, a lot of the time, what I said at the beginning, is that we see these systems that are really not optimally meeting our patients' needs. And I think a lot of times when you continuously see these problems, it's easy to either kind of accept them and give up and be like, oh, that's just the way things are, or just to ignore them and be like, well, that they don't really exist. Let's just continue on. But I think ultimately we should just be acknowledging them and trying to change them at the same time. So